University of Mumbai, Tata Memorial Hospital, Radiation Oncology. And he was fortunate enough to do another residency in radiation oncology at the University of Wisconsin in Madison. And luckily for us, joined the University of Maryland in 2014 and has a special interest in gynecologic cancers and also proton therapy. Thanks.
Thanks, Gautam. Well, thank you all. It's great to be here. Thank you to Carrie for she went out for organizing, and Dr. Contact, and I don't know if you are Dr. Contact, well, thank you for having me over. And again, I guess the theme of our presentation today was gynecological malignancies, and we were going to talk more about the role of radiation therapy. The focus would be still to kind of get you guys introduced what radiation oncology is about and how we approach cases and what our life typically runs around. So I wouldn't be getting too deep into the true oncology aspects of gynecological cancers, and I assume a lot of those talks will eventually be done with Dr. Rao and Dr. Roque. I do not have any conflicts of interest. I did borrow a lot of images from Google. And so acknowledge all those anonymous sources. The overview would be radiation therapy, just very quickly looking at overview of history, the radiobiology. I was initially including some physics slides. I know I was speaking with some of the residents in the tumor board, but it was becoming too big, so I landed up deleting all of those. So hopefully I wouldn't be torturing you on that. And some ideas on how we decide on radiation dose and fractionation, types of radiation, radiation devices, the planning process, and then we'll quickly jump on to role of radiation in the predominant gynecological malignancies that we are involved with, cervical, endometrial, a slide on vulvar cancer, and we'll do that looking at case examples that I've been involved with Dr. Rao and Dr. Roque. So life in Budelsky basement can be pretty interesting for us. I don't know how many of you ever actually went there. But as this really lovely lighted stairs comes down, and I took this picture 2 days ago and did not realize it really looks very beautiful. And this is that entrance on top is where is a Lombard and Green junction, which is where people come in through. So types of radiation, we think of radiation as a really long spectrum on the electromagnetic wavelength, from ionizing and non-ionizing radiations being component of that. X-rays and gamma rays, which is what we mainly use for our treatments, are on the other end of spectrum, completely opposite to the radio waves and the photon energy that we think of as infrared, visible light, UV, and X-rays. We know the X-rays have been with us for a very long time. First discovered in 1895 as a lab kind of experiment / accident, and the X-rays of the hand was very famous as the first radiograph that was actually created. And then a lot of pioneers back then, including Dr. Becquerel, discovered natural radioactivity. Marie and Pierre Curie spent a lot of time isolating natural radioactive sources. And in 1903, all three of them got the Nobel Prize for their shared discoveries. Incidentally, gynecological cancer history and radiation therapy is also that long. Radiation was one of the first treatments for gynecological cancers with use of brachytherapy way back in 1903, as it was started there. And since then, obviously, things have evolved a lot. But I think we, as a field, should be very proud that we were one of the starting zones for use of radiation in the field of cancer. How does radiation work? Our patients are always interested in knowing that. Basically, as we understand now, it really damages the DNA, which is the main target of injury within the normal cell and the cancer cell. And radiation can cause various elements of single-strand or double-strand breaks that ultimately, if they're not repaired, they accumulate, and then the DNA structure breaks down. That affects the cell division, and that's how the cancer cells die. This also happens in the normal cells, the difference being normal cells have repair machinery, and they are able to repair over time. That's why we get side effects, but ultimately patients are able to recover from most of those. When we think of radiobiology, there are the mainly 4 R's of radiation that we think about: repair, repopulation, redistribution, and reoxygenation. And essentially, these are the reasons why radiation treatments are not done typically as a single shot process. These are done as fractions or multiple treatment sittings done over an extended period of time that can range into many weeks. The idea being that normal cells can repair radiation damage typically in 6 to 8 hours. And so if we keep doing radiation dose in small treatment doses, between each treatment fraction, there will be some repair of normal tissues, and ultimately body will be able to tolerate the course of radiation, whereas for cancer cells, each dose just keeps building up because they don't repair as effectively, and ultimately it leads to a cell kill. The one other R that we now understand a bit more is inherent tissues inside the body, and cancer cells themselves can have differing radiosensitivity. With lymphoma, small cell lung cancer, seminoma, HPV positive oropharyngeal and cervical/vulvar cancers are also very radiosensitive. The radioresistant varieties are the renal cells, melanoma, glioblastoma, and tumors like that. And that is the reason why some tumors, radiation is part of the curative treatment. For others, it's more of an adjuvant treatment to take care of microscopic disease. And like I said, even in the body, there are various tissues, some of which can tolerate really high amounts of radiation. For our field, cervix and vagina, as parts of gynecological setup, can actually tolerate pretty high doses of radiation, which works in our favor because we're able to give that high dose of radiation and try and cure the cancer without too much of significant damage to the surrounding structures. For radiation, it's also a lot about volume effect. A small dose to a big portion of the body is more toxic than a very high dose to a very small portion of the body. And that, in a sense, is the reason why brachytherapy, and we'll talk about that, what brachytherapy is, where we put radiation sources directly or through plastic channels right inside the tumor, and through that we can give a very high dose of radiation to a very small portion of the body, which is tolerated. But if we were to do that same radiation to a bigger area in the body, it will not be tolerated, or we will have to go really very slow. And again, that component also for gynecological radiations, whether we are treating whole pelvis or are we treating whole pelvis plus para-aortics, all those factors play in the ultimate side effect profile from the treatment. So based on all these factors, the 5 R's, the body site that we're dealing with, the histology, the volume that we are going to treat, the treatment intent, and patient factors, we account for all these when we decide our ultimate radiation dose. And what is the unit of radiation dose? For our clinical life, it's really gray or centigrade, or most of the older textbooks, including radiation oncology and I presume gynecology oncology textbooks, talk in rads. But basically 100 rads equals 100 centigrade equals 1 gray. There are other units for radiation exposure and radiation precautions as well. And as I mentioned, we fortunately again get a role in a variety of different scenarios in oncology that can range from definitive treatment as a standalone, usually or more oftenly combined with concurrent chemotherapy as a radiosensitizer for curative intent treatment, or as neoadjuvant treatment where we are delivering radiation, again alone or in combination with chemo prior to surgery, which is then considered the primary line, or adjuvant treatment when radiation with or without chemo is delivered afterwards. And we think of that like as a mop-up operation or insurance for taking care of any microscopic residual disease. And again, we play a very important role in palliation for advanced cancers that are not responding to systemic therapy or causing a lot of symptoms. As far as types of radiation is concerned, it's predominantly again divided into external beam radiation, where the radiation source is a big machine which is pointing radiation from outside the body, and that includes linear accelerators, proton beam therapy, heavy particles, versus brachytherapy or internal radiation, where the radiation source goes inside the tumor location and emits radiation from inside out, and thereby maximum amount of radiation is given to the tumor and less to the normal tissues. But again, just the machines that we normally any department would include. The linear accelerator, as I tell my patients, just like a really big, very heavy X-ray machine that is very complicated and can deliver treatments despite its big size to millimeter scale accuracies, which is the reason we can deliver some very precise treatments in critical locations like brain and other parts. Other machine that you sometimes hear about called as tomotherapy, which is basically a CT scanner that was made into a linear accelerator combined technology. So the CT scanner can also deliver radiation treatment as a circumferential treatment that allows more degrees of freedom for us to get very tight with our radiation doses. Prostate brachytherapy is very commonly talked about, where we actually place radiation seeds right inside the prostate as an invasive procedure, typically done with our surgery colleagues. And the seeds stay in there. These are very low dose emitting radiation seeds. They stay inside the body forever. Over time, they just die out of their radioactivity. But during that process, they kill the cancer cells within that. Breast brachytherapy is a very commonly used treatment where, through a variety of approaches, we either put plastic catheters in the surgical bed or single lumen or multi-lumen balloons in the surgical cavity. And through these lumens, we connect it to the radiation machine, and then those tiny radiation seeds go inside that and give radiation to that target volume. And then ultimately all these catheters come out. Gynecological brachytherapy is a very important component for us, and I'll be spending some more time on that. So what is a radiation treatment planning process, and what happens before a patient enters this really broadly labeled caution high radiation area that scares the person as soon as someone's entering? But our typical workflow starts from a lot of consultation and a time that we spend in clinic with patients doing the initial evaluations and examination, to simulation and planning. Before actual start of treatment, a lot of on-treatment evaluation that we do jointly, like in this case with Dr. Rao and Dr. Roque, for their toxicities, and then we participate in their follow-up assessments. But really the step that happens in between, called as the simulation and planning, is kind of one of those black box areas that to other providers, you really don't get to know what's happening in the basement and why there's a bit of gap before we actually start treatment. That's an area of anxiety typically for patients. Sometimes our referring providers can get angry. Fortunately, I have the ever so composed Dr. Rao and ever smiling Dr. Roque, and that's never an issue. But again, that can definitely cause some anxiety to patients. And the reason is that small window between the consultation and start of treatment, there are a lot of steps that happen from the planning CT scan to contouring, where we actually draw out on CT scan the target volume, which is the tumor, draw out the areas in the body where the cancer may spread to, and then draw out on a CAT scan basically every normal tissue that may be in the vicinity. And then our dosimetrists and physics faculties will create a radiation design on computer, which is why it is called a simulation. It's really like a very fun video game session, and after that, there's a lot of quality assurance process that goes through before the actual treatment starts. And that simulation lands up being the longest appointment, because this is where we decide how best to position our patients for the course of their treatment, so that the patients are lining up very consistently over the course of treatment. And there are a variety of immobilization devices that we use to help with that, including face masks like these for head neck cancers, some body masks for patients who need craniospinal irradiation, a lot of vacuum beam bags that we call as vac logs that help position the patients, actual rigid frames like for radiosurgery for the brain that can sometimes be used. Specifically for gynecological cancers, because that's the pelvis, the two main positions that I try to look into is either just supine or prone. And clearly supine is a very easy position for patient to lie in. We use the vacuum bag, and it takes the shape of the body contour. That way patients are aligned perfectly every day. But there are some advantages of aligning a patient in a prone position, namely related to the bowel tissue. When someone is prone, and again, this is not someone standing and this is not a pregnant lady, this is really someone who's lying prone, and as a result of that, that entire anterior abdominal wall protrudes out by gravity and pulls it away from the target area where we want to give radiation, and that allows a lot of small bowel, which is a very sensitive structure, to move away from the radiation field. Whereas if you do the same thing supine, all the bowel loops tend to fall down into the pelvis, and that can increase toxicity, and then we have to rely on bladder filling to push the bowel loops away. And again, just an example of supine versus prone. By doing prone, these bowel loops are able to move away from the area of target radiation, and thereby we can minimize to some extent radiation effects. As radiation treatments, external radiation evolved, we've moved from 2D radiation therapy, where we would just use X-rays and look at bony anatomy to decide how best we want to target or send our radiation beams. But that has evolved to using more of CT scan-based planning, what we call as 3D conformal radiation, which is where on a CAT scan we basically spend a lot of time delineating the target volume, and the normal structures, and then our physics and dosimetry creates a radiation design, and we can actually see in the body where radiation is going through, how much radiation is going to which structure, and ultimately get these what we call as dose volume histograms, so that for all structures like the target volume, we want to give them maximum amount of dose, but for all normal structures, we want them to be as far left as possible, so that there is a big gap between that, and that provides the therapeutic effect or the therapeutic ratio. The more current form of radiation that is an advancement of the intensity of the 3D conformal is the intensity modulated radiation, and the difference basically is with 3D conformal, we are just basically shining radiation beams from fixed beam angles, and there's not much we can do in terms of controlling. That means if you have to treat an area, a horseshoe-shaped area like that, a typical cervical cancer fields will have 4 fields, but entire box like this will get radiation. But by using intensity modulated radiation technique, we can pretty much shape our radiation beams to the target volume, and thereby we are able to reduce the dose to bladder and bowel structures or any other critical structures. But that is where it generates a lot of extra time for radiation planning. The coolest tool that we have right now, again, you guys may have heard of the Maryland Proton Treatment Center, which is a joint venture with the Greenebaum Comprehensive Cancer Center and School of Medicine, which uses protons, which are basically charged particles, as we know, in the shell of neutrons, in the shell of an atom. And the difference is when we shine photons or X-rays in the body, it builds up in the body and basically just penetrates through and through. That's how we get X-rays. On the other hand, when we send proton beam into a body, it enters the body, and at certain specified distance, we can control for it to actually deposit all its radiation dose, and everything beyond that is there is no radiation at all. And that can be very beneficial in a lot of scenarios, like if we have to treat the para-aortic chain here with VMAT, and again, this is a really good design because all the hotness or the high doses is at the center, and we can minimize radiation going to the kidneys, the stomach, the liver, and other structures. But with protons, we basically just shine 1 or 2 beams from back, and there's essentially no radiation to any of these areas. And that makes it really very important for reducing the risk of side effects. And that's our proton center. That's a few blocks away. A really big $200 million investment by the School of Medicine and with private. The protons are accelerated to almost 2/3 the speed of light, which is really interesting, and that's how high energy they need to get to 250 million electron volts to be able to penetrate the body in a manner. And the generating machine for that is a cyclotron, which is like a 90-ton machine. So this is really a very cool facility for all of us and a very important resource for our patients. Again, just a couple of patients that I'm treating right now. This is a 46-year-old with low-grade endometrial stromal sarcoma that was unresectable. And so we decided to use radiation, but just a comparison between protons and photons. By using just 2 beams, I'm able to focus all the radiation on that gross tumor and minimize the radiation going to the bowels, which for this young patient can mean an impact on the long-term side effects. Another patient, another young 46-year-old vulvar fibrosarcoma was resected at an outside hospital, had closed margins, and so we had to treat. And again, imagine treating this by in the area of the skin will end up giving so much dose to the pelvis, but using protons, we can pretty much limit the dose to the extent. In her case, we were able to limit dose even to the ovaries as well, and she basically kept having her regular menstrual cycles going through the proton treatment. So that's as far as a very quick introduction. I know we started a bit late, so we'll get moving on to our primary topic. Again, looking at an overview of radiation therapy for cervical endometrial cancers. We know cervical cancer is more common for the developing world and a world issue, and not as much as an issue in the U.S., but especially in the area where we are around the Baltimore, Maryland area, socioeconomically challenged or underprivileged population, where HPV vaccines are not that very commonly used. This is still an important cause, and that's why our GYN oncology programs gets to see a lot of that. As a radiation oncologist, for staging for cervical cancer, to simplify, what we mainly look at is stage 1A, which is where the disease is still localized to the cervix, or 1B, where it is bigger than a few millimeters or thick and is bulky, but still localized to cervix, to 2A, where it extends to the vagina, 2B, where it extends to the parametrial tissue, 3A, where it goes all the way to the lower extent of vagina, 3B, where it extends all the way to the lateral pelvic wall, and 4A, when it starts involving the bladder and rectum or if it is metastasized. As far as an overview of treatment, our role in the stage 1A1 and 1A2 is very limited. Again, these are areas where we predominantly rely on a surgery, either a fertility-sparing surgery if patient is young, with conization or extrafacial hysterectomy or a trachelectomy, to more extensive surgery, which is the ideal surgery, which would be the modified radical hysterectomy. But as the tumor starts getting bigger, as we go from 1A1 to 1A2, 1B1, that's where the role and the junction transfer of hands from surgery being a based approach to radiation-based approach happens, and that has been basically tested through studies where, like in this study, the criteria that we look for is for early stage cervical cancers. When we perceive that risk is high, is if they are bulky tumors more than 4 centimeters, is they're involving very deep into the cervical stroma, or there's a lot of lymphovascular space invasion, and then adding post-op radiation can actually lead to significantly improved recurrence risk with a trend to improvement of survival. But if the risk is even higher than that, when there are pelvic lymph nodes involved, or there is actual parametrial tissue, or positive margins, then radiation alone is not enough, and then we need to add a concurrent chemotherapy regimen combined with radiation to help improve not just the local recurrence rates, but also improving the survival outcomes for ladies with cervical cancer. And that's the reason why, as we tend to get more and more bulky disease, if we were to use primary surgical treatment, they would still need a full dose of radiation and chemotherapy, and then they'll end up getting side effects from all treatments without necessarily any benefit from the combination. And that led to actual studies being done, like in this 1B2 population, the Landoni trial, where they'd really tried looking at randomizing between surgery and radiation, and in bulky patients or patients with higher risk, there really was no significant difference in outcomes overall in survival. However, when we started with surgery, they would need additional radiation, which would add to toxicity. And that's why as we go from 1B2 to onwards to 2A and all the way to 4A, pelvic radiation with concurrent cisplatin-based chemotherapy and brachytherapy lands up being the standard of care, and adding radiation and chemo together leads to improved recurrence, locally distant mets-free survival, and overall survival. And once we go beyond to 4B, or really distant metastatic disease site, that's when the hands again get transferred to predominantly systemic therapy-based regimen with using radiation as a palliative measure. When we're using radiation for cervical cancer, the primary target volume is the whole pelvis. Again, from both standpoint, the questions that typically sometimes come even in GYN oncology side, what radiation dose is used typically is 45 to 50 gray of 1 treatment per day, Monday through Friday, 5 to 5.5 weeks. And again, coming back to that radiobiology, because we are treating a big area of the volume, we have to do this treatment slowly for the body to be able to tolerate it. And we are very selective of treating the para-aortic nodal chain, because that will further extend the treatment volume and increase side effects. If there are gross lymph nodes that can sometimes be seen, then we have to boost those lymph nodes to as high a dose as we can that our normal tissues can allow. Patients get concurrent weekly cisplatin, 40 milligram per meter square, going through the course of chemoradiation. And then towards the end of this phase, that's when the brachytherapy treatment starts, which is typically 4 to 5 treatment procedures that are done as a joint operation with our GYN oncology team to place the Smith sleeve and then the radiation devices. And again, I'll show you some images on that. But typical radiation fields, again, just the buzzwords on that, is a 4-field box technique like we talked about, which just basically shine 4 big radiation beams from the front, back, and 2 sides, and that lands up giving radiation to an entire box of tissues in the body, like we saw initially. And again, we get an idea of the radiation doses to all these organs using 3D conformal treatment, and try and minimize as much as we can radiation dose to the femurs or the bowel tissue higher up. Sometimes you have to treat the para-aortic nodal chain. This is a patient that I shared with Dr. Roque, had 1B2 disease, but she also incidentally had a pelvic lymph node that changes the ADCC stage, so we had to treat slightly higher up along with concurrent chemotherapy. And she also participated in a clinical trial that's actually open at our cancer center, where patients are being receiving additional chemotherapy after their concurrent chemoradiation is completed in patients with locally advanced cervical cancer, so we can further improve their outcomes. And like for that patient, when there is a nodal area involved, then after doing that big 4-field box, we then cone down and do much tighter radiation beams just around where the radiation node is. But that's where I said that it really depends upon where the node is placed and how much bowel tissue is around, because we are limited by bowel tolerance. And this patient, I'll mention about that later, unfortunately ended up getting a really bad radiation toxicity with fistula formation. For patients that are already post-hysterectomy, and for the reason that we noted, the list criteria or the Landoni or the Peters criteria, we land up using IMRT more than 3D conformal radiation, because in a post-op setting, when there is no intact uterus, all the bowel loops again tend to fall down into the pelvis, and we really need that method to try and minimize the radiation dose between the two target volumes, wherein IMRT comes really handy, and we can focus all the radiation to the lymph node volumes and spare radiation dose to the bowel or the bladder structures. Once the external beam radiation is finished, then for patients with intact cervical cancer, then we start moving into the zone of brachytherapy. And a typical brachytherapy for intact cervical cancer, the terms that you know about are the tandem and ovoid placements. And in addition, we place what is called as a Smith sleeve, which is a plastic device that is placed right through the cervical os on the first procedure, and that basically provides us access. The Smith sleeves are placed by the GYN oncology team, and through that Smith sleeve we are able to place our central uterine source called the tandem for the remaining procedures, and then we place additional instruments called as ovoids or now rings in the vaginal area. And using these approaches, we are basically able to give a very high dose of radiation just to this portion of the uterine, cervical, vaginal, parametrial anatomy, which is where the highest dose is. And that's why this is called as a boost treatment after the initial external beam radiation is completed. There's also obviously been a lot of evolution from 1903 when the first radium feeds were implanted into cervical cancer to where we are right now, from low dose rate to high dose rate to use of image guidance. And the biggest change that I think very relevant for the GYN oncology teams and people taking boards is the change of prescription from point A, which is completely everywhere in all textbooks, to more of a volume-based definition. And again, the devices really evolved from simple rubber-based instruments that were in multiple pieces in which radium seeds or radium needles were actually placed, to more metal-based instruments that have now evolved. And then more recently, these have evolved into plastic-based instruments that are CT and MRI compatible, so that we can do radiation treatment and still do a CAT scan on them. The other evolution was to move from ovoids to rings. It just makes it a bit easier as a procedure. There are pros and cons to both of those. It's an easy assembly with ring, but I think dose to far lateral parametrial tissue does sometimes get compromised with the ring as against ovoids. But a lot of clinical centers have moved to using rings, and the outcomes seem clinically very comparable. As far as the radiation dose, again, the older low-dose radiation was when we would give less than 2 gray an hour kind of a radiation dose, to now as much as 12 gray an hour. And the entire radiation treatment with brachytherapy, originally with LDR, would span for 24, 36, 40 hours of procedures where patients would be with the radiation devices in the hospital, to now moving to really 5, 10, 15 minutes of treatment. So that can be done as a daycare procedure, which makes it a really easy on the patients. Again, there are advantages because of that high dose radiation. It's done quickly. It's an outpatient treatment, and allows us much more flexibility in terms of designing treatments, and I'll show you some examples of that. So this was again the point A. The conventional definition of point A was you go to the os, go 2 centimeters up, go 2 centimeters to the right, and that becomes your point A. And that was reflective of what we felt to be a dose limiting area where the ureters would cross the uterine artery, and we would not want to give a dose higher to that area because it would lead to really complications. It was more of a dose limiting structure-based definition. And then there were additional points defined, like the point B, which was 3 centimeters further lateral, and that would represent the lateral pelvic wall or the lateral parametrial or the nodal area. But this was really way back in early 1930s and 40s as the radiation systems were defined. Back then we would use a Foley balloon and either some contrast in the rectum or just a spacer in the vaginal tissue to decide where the rectum lies and where the bladder lies, without really giving any consideration to what the actual volume of bladder or rectum may look like, but just use point-based definitions of what our radiation dose tolerances would be. And the X-rays in that scenario would basically look like a standard front view, AP view, and a lateral view where you can see the device placed in. This is the Smith sleeve that you can see the area, and this is the ring place. But as you can imagine, we really get no idea of where exactly the bladder is, where rectum is, where the tumor is, or anything of that, and that becomes very limited. And so over a period of time, things have evolved, especially now as we get to do more and more imaging. The conventional point A, like this example, again another patient of Dr. Roque and mine, if we were to do a standard point A based definition, point A would have lied inside a sigmoid, and we would have given our entire dose to sigmoid, leading to toxicity, which is clearly not necessary. Other areas is where tumors are very big, where a traditional point A definition would not cover the tumor very well. And now we have that information, and then we can do certain things to try and improve radiation dose coverage to that area. Even the bladder and the rectum, depending upon how much the bladder is filled up, if you're just using a Foley balloon, the Foley balloon position is very consistent between both, but the bladder dose can depend a lot upon how much the bladder filling is and where the bowel are located. Again, all that information cannot come from just 2D based planning, and we have to move to a 3-dimensional planning. I think we went through the slides. Also, 3D based planning provides information about sometimes when perforations happen, where we feel that we are placing the tandem inside the uterus, but because of the friable anatomy, it just pierces through and through and goes posterior. And in this case, on an X-ray, this would have looked perfect, and we would have given radiation all the way to the sigmoid, leading to complication, whereas now through image guidance, we are able to pick these up and either abort a procedure or modify the treatment. And because of all these reasons, we have over time moved to a 3D-based image guidance process where we rely on CT scans and MRI and are able to actually draw out our target volumes, draw out our normal structures, and then I can play around with the optimization process to try and get as much of radiation dose to the tumor, but try and minimize radiation to the normal tissues, and then get actual dose objective measures to the organs in general. And we have our constraints for the normal tissues, and we have our target for the tumor area that we want to prescribe to. And that's a reason why now all modern centers are prescribing not to point A, but to something called as HRCTV, or high risk CTV, that includes the entire cervix, any visible disease at the time of brachy, and any areas of gray zones that we see on the MRI that may be suggestive of residual disease in the parametrium. So the gross tumor and the HRCTV is what we prescribe to, and then we have other structures to guide our doses. And even in the image guidance, the move from CT to MRI provides even further added information for us to fine-tune our treatments. As you can see from here, and MRI really provides us a good idea of where the doses, where the tumor is actually extending into the parametrial tissue. And just a CT-based volume would have treated only the central structures, but now with MR-based planning, we can identify the areas that are at higher risk and try and give additional radiation treatment to that location. Again, these are just some clinical series, but for sake of time, I'll skip through that. This was our first case. I moved here in 2014, and again, we had been doing a lot of MR-based brachytherapy in University of Wisconsin, and so as we moved here, I initiated that process, and I think this was a patient, I remember it may have been Dr. Roque's and mine, or I forget, or was it Dr. I'm sorry. But in any case, so now we do the MRI at the time of brachytherapy insertion. We can actually see the device in relation to the tumor, and then I can do a 3D brachytherapy planning and try and give as much radiation treatment to the tumor and really minimize radiation going to these normal structures. We also land up using a lot of ultrasound at the time of our placement, because again, when we are placing the tandem inside the OR or the Smith sleeve, it's in a sense slightly a blind procedure that can lead to risk of perforations, but by using ultrasound, we can actually see where our tandem is going, and that can help reduce the risk of perforation. I think it also is a good residency training experience. The residents get to see where exactly the tandem is going. And sometimes we see obstructions in the path because of a fibrotic tumor, and then the tandem's not going through, but with ultrasound, we know where to push, and we just push it harder, and then we are ultimately able to navigate that obstruction and reach the top of the cervix. Again, as I said, I do try to use bladder filling as a means to avoid radiation dose to the bowel, and that's because bowel is much more sensitive to radiation toxicity than bladder, and between the two structures, we land up sacrificing bladder so that we can reduce the dose to the bowel. So as you can see here, this bowel loop, if we had treated on empty bladder, would have got very high dose of radiation, but by using a filled up bladder, I'm able to push the bowel loop away, and it increases dose to the bladder, but we know what the bladder can tolerate. And we talked about the MR base. This had the same patient where the point A lie in the sigmoid, but because the MRI confirmed a very good response, I felt comfortable getting tighter in my radiation volume, so I can reduce the dose all the way from point A just to the target volume. So if you look at my point A dose, it's only about 300 gray, or 300 centigrade or 3 gray, whereas my target dose was actually 5.5 gray. So that's why, again, point A is no longer relevant for our brachytherapy planning in the current era, but we still keep track of it as a monitoring approach. For the tumor example that I showed where it was really big and our traditional point A would not have covered, that's where we land up using modified devices that we have called as the ovoids or rings with needles in addition that basically go into that parametrial tissue, and through these needles I get extra radiation channels from where the radiation source can go through, and now I not only have the central tandem and the ring, but I have these extra needles that go all the way into the parametrial tissue. I can get almost like an oblong shaped distribution of radiation and limit the radiation going to the bladder and the rectum, which ultimately is expected to improve outcomes. There are times where we cannot place a ring inside because the vaginal cavity is really narrowed out. In those scenarios, we have what we call as the tandem and cylinder applicators. The cylinders can be a variety of sizes. They just go in. But because there is no ring or ovoid, it does limit the dose spread to the lateral parametrial tissue and make it more elongated, and that can slightly increase the risk of dose to the rectum and the bladder. But again, we have to get the radiation dose in, and so we have to accept that higher risk for those scenarios. Even more advanced cases is where we move into what we call as interstitial brachytherapy, where even the two needles to the rings are not enough, and we have to put many more extra needles all the way through perineal tissue. Again, this is a giant procedure that's done through GYN oncology, and a lot of time investment goes from the inpatient team because the patients stay admitted with this device in for up to 3 to 4 days, where these needles have been penetrated through the skin. They are under epidural anesthesia. But because of that, we are able to give very high dose radiation all the way to the tumor that is much far beyond the reach of a tandem and ring brachytherapy. In addition, here at the University of Maryland, again, we are fortunate to have a very unique modality that in addition to radiation, we are able to use what we call as interstitial hyperthermia. So using those same needles, which is what we would have used for radiation, we are now able to have some heat basically go through that physically heats up the tumor. And even though generally patients like to think of radiation will burn the area inside, there's really no heat involved. It creates an effect like burning, but it's through radiation damage. But now we are actually adding heat to it, and that's because, again, a lot of preclinical and clinical data has suggested that adding heat actually make the tumor much more responsive to the radiation effect. And so we use that for all our locally advanced cases that have a lot of radiation disease, a lot of residual disease that has not responded to standard radiation. Moving on to endometrial cancer. It is the most common cancer that at least you all see in your fields in GYN oncology, again, we have some role for radiation here. Overall survival outcomes depend upon the stage, whether it's confined to the uterus or it invades to the cervical stroma, or does it involve any adnexal structures or lymph nodes or any distant metastatic disease in the body. And it again goes from using more of primary surgical based approach for stage 1 and stage 2 and stage 3, but adding radiation and chemotherapy as adjuvant treatments for more for stage 1B, 2, and 3 in different forms, and we'll talk about that here. Why don't I skip this? But basically what the literature study showed is for early stage endometrial cancer, just doing surgery alone was not enough, and there would be higher risk of recurrence. So we actual randomized trials documented the clinical benefit that would come in local recurrence by adding whole pelvic radiation, which was the initial FORTEC-1 study in Europe and the GOG study. But through these both studies, we were able to identify what we call as high risk factors, which is deep stromal, again, deep myometrial invasion, grade 2 or grade 3 disease, lymphovascular space invasion, and age as a risk factor. And for older ladies, any of these factors makes them a higher risk, whereas for younger patients, they need 2 or 3 of these factors, and then we have to consider additional treatments beyond radiation. As time evolved, we were trying to figure out whether do we really need to treat the entire pelvis, or can we just treat the area of the vaginal cuff, which is the highest area of risk of recurrence. And again, a randomized trial from Europe, the PROTECT 2, showed that there is no difference between using external beam versus just vaginal brachy. And by using brachytherapy, we are able to significantly reduce the toxicity that comes with whole pelvic radiation. And so currently, our standard of care for anyone with grade 1-2 disease 1B or grade 3 1A is to consider vaginal cuff brachytherapy and reserve external beam radiation therapy for more patients beyond stage 2. This is how a brachytherapy with a cylinder would look like. Because there is no intact uterus, there is no tandem device, so we insert just a cylindrical device inside the vaginal tissue, and through that we are able to deliver a high dose of radiation just to the top portion of the vaginal cuff. It does still give radiation to the bladder and rectum to a small amount, but as you can imagine, if you were treating a whole pelvis, all those bowel and bladder and lymph structures in the pelvis would have got extra radiation treatment. But for anyone with stage 2 high-grade disease or stage 3, that's where we have to move from vaginal brachy to whole pelvic radiation, typically combined with full course of systemic chemotherapy. And in that scenarios, we again come back to that standard 45 to 50 gray external beam radiation treatment with or without use of additional brachytherapy as a boost to the vaginal cuff. And then there is chemotherapy that happens. Again, there's a variety of regimens that are used for using chemo and radiation in combination that range from starting with chemotherapy and doing radiation to the end, or starting with chemo, doing radiation in between, and then doing more chemo at the end, called a sandwich therapy, or starting with radiation and doing chemo all the way to the end. And there's pros and cons to all these approaches. I think our approach here has always been using completing all the chemotherapy up front and doing radiation later on. But in scenarios where, for whatever reason, this is a patient that Dr. Rao and I share, that that patient was started on chemotherapy and had a really bad, I think a renal issue or something, and could not complete chemotherapy. In that scenario, we then have to cover up for the fact that a pelvic and para-aortic nodal chain is at risk, and then we land up treating not just pelvic fields, but we land up extending our volumes to the para-aortic nodal chain, which slightly increases the risk of toxicity, but that's when, again, we use our modern radiation techniques to try and reduce the dose. This was a research that we presented at ASTRO from our GYN oncology team, where we really tried looking at our national cancer database to try and see, is there any difference between that 45 or 50 gray? And it turns out that for patients who don't need boost, there was actually a 3% survival benefit that came by using a slightly higher dose. And so I'd like to use 50 to 50.4 gray in those higher risk scenarios. We also tried looking at what is the impact of sequence of radiation, and again, it kind of confirms our practice that patients who got upfront chemotherapy tended to do better than getting upfront radiation, and likely reasons for that is potentially adding radiation upfront adds to the toxicity from the treatment, and then patients are not able to complete their planned course of chemotherapy, which then leads to increased risk of distant mets or recurrences, and those patients then have inferior outcomes. And as a result of that, now our team again is starting to work on a concept using protons, because again, as you saw, even with IMRT, there is radiation dose that goes around to the bowel, but using protons, we'll be able to limit all that radiation dose, which generates a concept that we will now start working on using upfront intensity modulated proton therapy and concurrent chemotherapy full dose for endometrial cancer, and we'll have radiation delivered with chemo upfront. We'll probably involve this as a couple of institutions together, but our cancer center would be the primary institution. There are some patients with early risk disease that, despite doing a very good surgery or sometimes using brachytherapy, there can be cancer recurrence. Typically, the most likely site of recurrence is the vaginal cuff, and that's the highest risk. And every now and then we see these patients. If that happens, then again we have to treat these patients with full dose chemoradiation with again 45 to 50.4 gray with weekly cisplatin, and then follow it up with what we call as again the boost. The boost depends more about what amount of disease stays after the external radiation. and this may be again a relevance for even for GYN oncology boards, but if the residual disease after external radiation and chemo is less than 5 millimeter, these patients can just be treated with a cylinder. If, however, the residual disease is more than 5 millimeter thick, then a cylinder would not be able to give enough dose, and then we have to use the interstitial procedure to get that extra dose to the surrounding structure. This is a patient Dr. Rao and I shared, and we treated her with interstitial radiation, and I think I may have also added hypothermia for her, and she's doing okay right now. This is a more recent patient, and I think George may remember this because he's writing a case report on this one. But a cervical adenoid basal carcinoma, she underwent hysterectomy previously, but unfortunately had a vaginal cuff recurrence right in this location. And as such, we treated her with pelvic radiation and cisplatin chemotherapy. And when we did post-chemo radiation MRI, there was still residual disease more than 5 millimeters. And at that point, that decision would have been an interstitial brachytherapy, which is a much more complex treatment, much higher risk of complications and lower outcomes. Fortunately, she had a reasonable amount of vaginal length available, and so we discussed with Dr. Roque, and she underwent a vaginectomy to take care of this gross disease. And just yesterday, I did her cylinder brachytherapy. Now that there is no gross disease, I can do cylinder brachytherapy. But again, because this cylinder brachytherapy is also unique, because instead of just using a single channel, which we use for post-op cases because everything is at risk and we want to give dose circumferentially, in her case, her tumor was more left anterior, so I actually placed extra needles within my cylinder, and I was able to give more radiation to that left anterior area and keep the standard radiation to the right side, to the rectum and the bladder, and we'll see how she does. Hopefully she doesn't have too much toxicity. But again, this provides us some unique skills, not as much of skills, but also applicators that we have to have in our armamentarium to use the right applicator for the right patient in different scenarios. Last few slides, vulvar cancer, I'm very quickly reviewing that. Not very common, so we don't see that a lot. When we see that, it can be still HPV related or young smokers, but in older patients it's related to lichen sclerosis or vulvar dysplasia. Most common histology is squamous. Melanoma, adenocarcinoma, and sarcoma, like the one that I treated with protons, are also seen. FIGO staging for vulvar cancer in the early stage is a bit complex. It really relies mainly on the millimeter depth, and that's the reason of that is it significantly impacts the need for a lymph node sampling, whether it's more than 1 millimeter thick or less. But by stage 2, it's involving adjacent structures. Stage 3 is involvement of nodes. Stage 4 is when there's fungating nodes or distant metastatic disease. And for stage 1 patients, the ideal approach is radical vulvectomy with sentinel lymph node biopsy and or lymph node dissection, ipsilaterally, bilaterally, depending upon the location. And again, like we said, nodal dissections are predominantly done for tumors that are thicker than 1 millimeter. If these are well lateralized, unilateral dissection may be okay, but if they are, if it's more central or if they are gross lymph nodes, then we need to do bilateral lymph node dissection. And then thereafter, adjuvant radiation therapy is given if the margins of this surgical resection are closed. The number we look at, and again, this may be important for GYN oncology boards, is the 8 millimeter on a fixed tissue. If it's more than 8 millimeter, we think of that as a wide margin. If it's less than 8 millimeter, we think of that as closed for vulvar cancer, and then we often recommend adjuvant radiation. Similarly with nodes, if there are more than 2 involved macroscopic nodes, 1 macroscopic nodes or 2 microscopic nodes, that's an indication that despite the surgery, we have to add radiation therapy to the pelvis, groins, and pelvis, groin, and the vulvar area to target for any microscopic disease that may be left back. We also, like I mentioned in my first slide, have an important role in palliation. And again, it's sometimes forgotten, but some of our patients, unfortunately, will not do well, and they will have disease come back locally or distantly. And any of those disease locations can cause a significant amount of symptoms. And if once they are not responding to systemic therapy or if there are a lot of symptoms, we can consider really short bursts of external radiation, typically 1, 5, or 10 radiation treatments just to the target, either in the bone, compressing the spinal cord, or brain spreads, or in the lungs, liver, or painful skin lesions, or like vulvar recurrences, fungating groin nodes. In all these locations, we can add palliative radiations and get a good response, and at least help in their quality of life as they go through systemic therapy or ultimately transition to hospice. despite all these modern technologies, clearly we are doing really spending a lot of time and investment to try and minimize toxicities. But some of our patients will get toxicities. Many of the patients going through chemoradiation will get at least some grade 2 symptoms. Grade 3 toxicity is typically 10 to 15% or less, and that can range from vaginal stenosis, especially vaginal brachytherapy is involved. That's why after they go through their chemoradiation, we will prescribe to them use of a vaginal dilator to keep the vaginal tissues flexible, not just from sexual function standpoint, but also for vaginal exams. Lymphedema can come, especially when we are treating whole pelvic radiation, especially if it is being done after a lymph node dissection. And that's where we rely on our physical therapy and lymphedema clinic members to try and take care of those 10-15% patients that may get lymphedema. Chronic cystitis or urethral toxicity can be very important for some of our patients, especially the long-term survivors. And again, I rely on the expertise from our colleagues in GYN oncology or urogynecology patients to help take care of their urinary symptoms. Chronic proctitis and bowel obstructions can also happen with radiation, like we saw in all these slides. Even with the very modern brachytherapy and external radiation, that portion of rectum and bladder is always going to touch the portion of the vaginal cuff or cervix, and we just have no way to try and reduce those to that areas, and that's why some patients will get serious toxicities. Pelvic insufficiency fractures can happen. So any patient who has gone through pelvic radiation comes many months later and starts talking about hip pains, we should always think about that and do an X-ray, because there may be either a femoral or a pelvic brim fracture that may require addressing. Second, malignancies can happen for patients who are really long-term survivors, especially 5, 10, 15 years out. And that's why, again, for more and more young patients, we are transitioning to use of protons whenever feasible, because of those differences that we saw, that it really focuses the radiation to the cancer area and minimizes radiation to the normal tissues. Reminder of toxicity, this is a patient Dr. Roque and I share. My patient, I count this as my toxicity. Unfortunately, a very young 1B2, the one that had that lymph node that we treated, and she accrued to the Outback trial, got adjuvant chemotherapy after chemoradiation, and unfortunately 1 year later presented with really bad fistula at 2 locations in the sigmoid and rectum. This has completely changed her life. Her cancer is controlled, and that's positive, but she is now heading towards a really major surgical approach. She has a stoma that will likely be permanent. And so these toxicities will happen, unfortunately, to a small proportion of patients. When they happen, they can change life. And that's why, again, our brachytherapy program and our radiation oncology program spends a lot of time really thinking about those steps in our simulation step. And that's why that simulation step where there's a gap, a lot of things are happening that will potentially affect patients' outcomes. So again, we reviewed the overall principles of radiation treatment, including various radiation modalities, external and internal. We reviewed the technical advances in external and brachytherapy treatments to limit toxicity and improve outcomes. We referred that radiation can be used as an adjuvant, neoadjuvant to surgery, or as a definitive or a palliative treatment. And definitive radiation is typically combined with concurrent chemotherapy as a radiosensitizer to improve the outcomes even further. And through various case-based examples, hopefully you guys were able to get a broad perspective of where radiation oncology comes into picture for various gynecological malignancies. Appreciative of our gynecology oncology program, a small but very expanding program, and a lot of us are working on that with a really good pathology and radiology support. Thank you for your attention. I'm happy to take slides, questions. Right, and so that was the one that I showed in the initial one. For patients that are, I'm treating whole pelvis radiation, I do try to look at positioning them in a prone position to allow the bowel loops to be falling forward. Yeah, this one, which is, so they are placed prone position, and basically there is a hole or a gap in the area of the abdomen, and that when the patient is lying in that prone position, that entire abdominal wall falls forward, and that allows the bowel to actually move forward and superior away from the area of the high dose radiation. That's a good question. What happens, however, is patients who are either overweight or are having pain or issues, they don't find themselves being very comfortable in the prone position, and then their day-to-day alignment becomes really messed up. And so it's a balance that we have to strike between being very consistent, which is much more easier for a patient in supine position, to certain benefits that come from prone position on a case-by-case basis. Anything else? Well, again, thank you. Special thanks also to the GY and oncology residents or the residents who work through the rotation to take care of my brachytherapy patients. I know we stay most of our time in that basement, but a lot of work happens at you guys' level, so thank you for taking care of that.